starting with the chemical mediators of inflammation. So we have this based on the source of mediators, cell-derived and plasma protein-derived mediators. So cell-derived mediators are present either as preformed molecules such as histamine in mast cell granules or are synthesized de novo such as prostaglandins and cytokines in response to a stimulus. They're usually produced by platelets, neutrophils, etc. So plasma-derived mediators are produced mainly in the liver, okay, plasma proteins, and they are present in the circulation as inactive precursors which require activation, for example, kinins. So they have tightly regulated actions, and these chemical mediators' actions are interrelated. So one mediator can stimulate the release of other mediators. Okay, so most act by binding to specific receptor on target cells, and they also have diverse targets. So target cell type varies depending on the type of mediator, and they are short-lived. They're interrelated, so they act on diverse targets and they are short-lived. So cell-derived mediators, so first you have vasoactive amines, so histamine and serotonin. So basically due to physical trauma or injury or immune reactions such as allergies and C5a, IL-8, all of these, so they're the stimuli for histamine for release. So histamine and serotonin are present as preformed molecules, especially in the mast cells, richest source, and blood basophils and platelets. And when histamine is released, it causes vasodilation and increased permeability. So you need to remember that histamine and serotonin are the first mediators to be released during inflammation. They're stored as preformed molecules. So actions, again we've discussed. In serotonin, which is also called 5-HT, 5-hydroxytryptamine, sources again platelets, neurons, and enterochromaffin cells. Neurons because it's a neurotransmitter, and platelets also. So stimulus platelet aggregation and antigen-antibody complex formation. So serotonin causes vasoconstriction. So antigen-antibody complex formation and also platelet aggregation. Actions are similar to those of histamine. It also increases vascular permeability. Next, arachidonic acid metabolites. Arachidonic acid is mainly derived from cell membrane phospholipids by the action of the enzyme phospholipase A2. So corticosteroids inhibit this. So it is derived from phospholipids. So again, then it can enter one of two pathways. So COX pathway, that is cyclooxygenase pathway, and the LOX pathway, lipooxygenase pathway. Okay, so COX pathway produces prostaglandins and LOX pathway produces leukotrienes and lipoxins. So lipoxins, remember, they inhibit inflammation, so we'll talk about that. And products of cyclooxygenase pathway, you have prostaglandins ED and iron thromboxane A2. Okay, so basically local effects, thromboxane A2, you know from pharma that it produces vasoconstriction and promotes platelet aggregation. PGI2, exact opposite. So vasodilation inhibits platelet aggregation. PGD2 and D2, so vasodilation and increased permeability. That's it. PGD2 attracts neutrophils. Okay, and systemic effects, so prostaglandins are responsible for pain and fever. Okay, and PGE2 causes cytokine-induced fever. E to fever. Okay. So products of lipoxygenase pathway, you have leukotrienes and lipoxins. So leukotrienes, so basically lipoxygenase pathway, you have 5-HT. Okay, 5-HT is basically a chemotactic agent for neutrophils. It is the precursor of leukotrienes. So LTB4, so it's a chemotactic agent. Okay, that you need to remember. LTB4, C5a, IL-8, and bacterial products. Okay, they're chemotactic, attract neutrophils. Next, it causes generation of ROS. Leukotriene CDE4. So what they do is they constrict everything. Bronchoconstriction, vasoconstriction increase vascular permeability. Lipoxins, they inhibit inflammation, they inhibit neutrophil chemotaxis and recruitment, and they inhibit leukocyte adhesion. So platelet activating factor, obviously the source is platelets along with that basophils, mast cells, etc. So action, it has multiple inflammatory effects. So vascular reactions, so it causes vasoconstriction, platelet activation, right? So clots and constriction, vasoconstriction and bronchoconstriction. At low concentrations, it produces vasodilation and increased permeability. Next, cellular reactions, so increased leukocyte adhesion to the endothelium and chemotaxis, and also platelet aggregation, obviously. Next, reactive oxygen species, they are chemically reactive oxygen-derived free radicals. So normally they are rapidly inactivated, but increased production causes cell injury. Cell of origin is leukocytes. Okay, mechanism of production, especially during phagocytosis, they generate these ROS to kill the ingested microbes. So types, you have superoxide anions, hydrogen peroxide, hydroxyl radical, etc. and UNO peroxynitrite, which is formed by a combination of superoxide with NO. So actions, you have physiological function to destroy the phagocytosed microbes and necrotic cells, and pathological actions, so endothelial cell damage, which causes increased vascular permeability and injury to other cells, and inactivation of antiproteases such as alpha-1 antitrypsin. Nitric oxide, it is a soluble gas, free radical gas, which causes vasodilation. Okay, Next, it was known as endothelium derived relaxing factor. So source, many cells such as endothelial cells, neurons in the brain, etc. So that is why neurons in the brain type 1 isoform, and next endothelial cells E type 2 type 3 isoform, and inducible is type 2. So NIE 1 to 3, neuronal, inducible, and endothelial type 1, type 2, type 3 to synthesize from L-arginine, molecular oxygen, and NADPH by nitric oxide synthase NOS. Next, action. So it is a vasodilator. It relaxes vascular smooth muscle cells. It controls inflammatory responses, and also it reduces platelet adhesion, aggregation, and degranulation, and also has microbicidal activity because it is an ROS. Cytokines and chemokines. So cytokines are polypeptides which function as mediators in immune responses and in inflammation, so acute and chronic inflammation. So they are secreted by many types of cells. So important ones are TNF and IL-1. So they are the two major cytokines involved in inflammation. So the source is activated macrophage. So basically, whenever there is a stimulus such as physical injury, inflammatory injury, or immune complexes or endotoxins, they stimulate the macrophages, okay, to release TNF and IL-1. So they have local effects. So what are they? Vascular endothelium, they increase the cell adhesion molecule expression. So adhesive molecules, they increase the expression, and they help in synthesis of other cytokines. Leukocytes, they cause them to become responsive to other cytokines as well, other stimuli such as endotoxins or LPS. And again, systemic manifestations, you have fever, you have leukocytosis, inflammation, acute phase reactive proteins increase, and there's a decrease in appetite. So TNF contributes to cachexia seen in some chronic conditions. Next, chemokines. So chemokines are small proteins which selectively attract various leukocytes to the site of inflammation. So they are classified into 4 major groups: C, CC, CXC, and CX3C. Okay. So actions, basically they cause chemotaxis of monocytes, eosinophils, basophils, and lymphocytes, everything except neutrophils. Remember this point, chemokines do not cause chemotaxis of neutrophils. Okay, they activate leukocytes and promote their recruitment to sites of inflammation. Next, IL-6 is produced by macrophages and other cells. It is involved in local and systemic reactions. IL-17 produced by T lymphocytes promotes neutrophil recruitment. Next, lysosomal constituents, you have neutrophils. They have 2 types of granules, a larger azurophil or primary granules. They contain MPO. MPO is large, okay, so large primary, P for primary MPO, so primary granules. And again, you also have non-specific collagenase, non-specific neutral proteases, acid hydrolases, bactericidal factors, etc. And smaller specific or secondary, smaller secondary granules, SSS, smaller specific secondary, you have lysozymes, collagenase specifically, gelatinase specific for gelatin, lactoferrin, plasminogen activator, histaminase, alkaline phosphatase, etc. Next, monocytes and macrophages, they also contain all these acid hydrolases, collagenases, etc. These are active mainly in chronic inflammation, monocytes and macrophages. Neuropeptides are small peptides such as substance P and neurokinin A. They are secreted by the sensory nerves, and their action is vasodilation and increased vascular permeability. Moving on to plasma-derived mediators, we first have complement, then kinin, and clotting systems. So complement system, we have 3 pathways of activation. So there are a group of inactive plasma proteins, so C1 to C9, C1 has QRS, so total 11. So classical pathway, it is activated by antigen-antibody complexes. Okay, that is important. Next, alternate pathway or propedin pathway. Okay, so it is there in the absence of antibodies, so you have LPS or endotoxin or yeast, cell wall, etc. Next, you have the lectin pathway, mannose binding lectin pathway. Next, you have functions of complement. So first, obviously, we have C5A, which causes chemotaxis. So it is a powerful chemotactic agent and also causes leukocyte activation and adhesion. Okay, and C3A also helps in leukocyte activation. Next, opsonization. So C3B acts as an opsonin. So it promotes phagocytosis by neutrophils and macrophages. Next, you have cell and bacterial lysis. So obviously, C5B to C9, that forms a membrane attack complex which causes cell lysis. It allows water and ions to enter into the cells and results in death. Next, you have increased vascular permeability. So C3A, C5A complement, they increase the vascular permeability and cause vasodilation, and that is why C3 and C5A are also called anaphylotoxins, because their actions are similar to mast cell mediators involved in anaphylaxis. They also activate arachidonic acid pathway, so lipoxygenase pathway especially. Next, there's an interplay between innate and adaptive systems. So complements play a role, and again other functions, you have clearance of immune complexes and apoptotic cells by C1q and C3. So that is why the activation of complement is controlled by cell-associated and circulating regulatory proteins such as C1 inhibitor, decay accelerating factor, DAF, and CD59. At 59 years old, you become DAF. Okay. Next, coagulation and kinin systems. So basically, inflammation and clotting system are intertwined with each other. So activated factor 12A or Hageman factor activates the four systems involved in the inflammatory response. So first, basically what happens is factor 12A, it can activate the fibrin or lytic system. So what it does is it converts plasminogen to plasmin. Okay, how does it do that? So it converts prekallikrein to kallikrein, so the kinin system. Then kallikrein, it converts plasminogen to plasmin, and then again that acts on fibrin, causes fibrin split products, and that's how the pathway goes. So activation of plasminogen to plasmin, activation of complement, etc. So activation of the kinin system. Okay, so kinin system is also activated. So this kallikrein, what happens is it converts high molecular weight kinin to bradykinin, which increases the vascular permeability and causes vasodilation and also causes pain. Bradykinin. Okay. Next, it also activates the alternate complement pathway because again fibrin split products, and also finally it activates the coagulation system. That is an obvious thing. So thrombin and all that. So kinin systems of factor 12A converts prekallikrein to kallikrein, which again splits high molecular weight kinin into bradykinin. So it increases vascular permeability, causes vasodilation and pain when injected into the skin. So kallikrein is a potent activator of Hageman factor and directly converts C5 to C5A. Finally, moving on to the outcomes of acute inflammation. So you have resolution. It is a process of complete return of the tissue architecture to normal. Resolution, return of tissue to normal. So this happens when the injury is limited or short-lived, or when there is no or minimal tissue damage, and when the injured tissue is capable of regeneration. Next, there could be organization or healing by fibrosis. It is a process of replacement of dead tissue by living tissue, which matures to form a scar tissue, and that is known as organization. So it occurs when there is plenty of fibrin exudation in the tissue or serous cavities, which cannot be removed or cleared, and it is there in the presence of significant tissue destruction. There is death of the tissue, and with inflammation in tissues incapable of regeneration. Next, this involves growing of connective tissue into the area of tissue damage or exudate, and then the scar is formed. Abscess, it could be another way. So it is a localized collection of pus. So if the area of acute inflammation is walled off by inflammatory cells and fibrosis, then the neutrophil products destroy the tissue and it forms an abscess. Next, progression to chronic inflammation. Chronic inflammation may follow acute inflammation, or in the beginning itself it may be chronic. So acute inflammation may progress when the response cannot be resolved. This may be due to persistence of the injurious agent or abnormality in healing process. Example, bacterial infection of the lung may begin as acute, but when it fails to resolve, it can progress to chronic and cause lung abscess, cavitations, etc. Acute osteomyelitis can progress to chronic osteomyelitis if not treated properly, and chronic inflammation with a persisting stimulus results in peptic ulcer, which may persist for months or years, and thus chronic inflammation. Next, morphological types and patterns of acute inflammation. So first, serous inflammation. So it is characterized by marked outpouring of a thin serous fluid. It is yellow, straw-like in color, and microscopically shows either few or no cells. It is just a fluid. Examples: a skin blister formed in burns, or any synovitis, so inflammation of the synovium, you have synovial fluid, and pleural effusion. It is a complication of lobar pneumonia. Next, fibrinous inflammation. So there is a marked increase in vascular permeability, which leads to escape of large molecules like fibrinogen from the lumen into the extravascular space, and it forms an exudate rich in fibrin. So this fibrinous exudate is mostly observed with inflammation in the lining of body cavities such as the meninges, pericardium, pleura, etc. So when a fibrinous exudate develops on a serosal surface such as a pleura or pericardium, it is known as fibrinous pleuritis or fibrinous pericarditis. So microscopically, fibrin appears as an eosinophilic or pink meshwork of threads or pink amorphous coagulum. So especially in fibrinous pericarditis, so you can see that in rheumatic fever, it is known as bread and butter pericarditis. Next, you can have abscess formation by suppurative or purulent inflammation. It is characterized by the production of large amounts of pus or purulent exudate. So microscopically, you can see neutrophils, liquefactive necrosis, and edematous fluid. So bacteria such as Staphylococcus, which produce localized suppuration, are called as pyogenic bacteria. Next, abscesses. It is a localized collection of purulent inflammatory exudates in a tissue, an organ, or a confined space. They have a central necrotic focus consisting of necrotic leukocytes and necrotic parenchymal cells surrounded by a zone of preserved neutrophils. Okay, there is a zone of preservation, and beneath that there is a zone of central necrotic focus. Next, you can have hemorrhagic inflammation. So especially when inflammation is associated with severe vascular injury or deficiency of coagulation factors, such as an acute pancreatitis. Next, catarrhal inflammation. So it is acute inflammation of a mucous membrane which is accompanied by excessive mucus secretion, and the appearance is described as catarrhal, such as common cold. Next, membranous inflammation you can see in Corynebacterium diphtheria infection. So epithelium is covered by a membrane consisting of fibrin. Okay, so you can see pseudomembrane formation here. Next, pseudomembranous inflammation you can see in Clostridium difficile colonization of the bowel, usually following broad spectrum antibiotic treatment. So it is characterized by superficial mucosal ulceration covered by sloughened mucosa, fibrin mucus, and inflammatory cells. Membranous in Corynebacterium diphtheria, pseudomembranous inflammation in Clostridium difficile colonization. Next, necrotizing or gangrenous inflammation, the combination of necrosis and bacterial putrefaction is called gangrene, such as gangrenous appendicitis. And an ulcer is defined as a local defect or excavation of the surface of an organ or tissue. So common sites are mucosa of the stomach or mouth, or peptic ulcers, and intestines, the genital urinary tract, and skin and subcutaneous tissue can have varicose ulcers.